Welcome. This is Brian Wood, Medical Director for the Mountain West AETC Project Echo Telehealth Program. Each of our weekly sessions starts with a short talk focused on issues relevant to HIV clinical medicine. The following talk was recorded live here at University of Washington. We will now take you to this week's talk.
Thanks, everybody. So the bulk of this talk is to give you all an opportunity to hear a little bit from Brandon, somebody that does tobacco treatment full-time and kind of what strategies he employs. But I will just start with a little overview of kind of why this is relevant in people with HIV, which is something you all are aware of. Just disclosing some consulting fees that are unrelated to this talk, and Brandon has nothing to disclose. And then here is the disclaimer for AETC Mountain West. And then I think this is a great slide on data considerations that you all supply, because we certainly do talk about those factors and intersectionality when we talk about health in any context with people with HIV. So I think this is a great slide. So what we're going to do today is I'll just start the talk and again, leave most of the space for Brandon, but reviewing the burden of smoking in people with HIV and the health impacts. And then Brandon will talk a little bit about our tobacco cessation care model and how we've kind of employed that. And really here at the University of Washington and Fred Hutch as a comprehensive cancer center, this is really the only tobacco treatment program, sadly, that we have. It's based at the Fred Hutch. So we hope to expand that in the future. We'll talk about counseling strategies, which I think is really important for folks on this call who are doing and participating in the direct care of people with HIV who may smoke, and talk about pharmacologic treatment, the do's and don'ts and best practices around that. And then finally, kind of exploring, which I would love to do with you all and hear your inputs on how you would tailor this process for people with HIV. So in terms of the smoking prevalence, I talked to you all who were on that call 2 months ago a little bit about that there clearly is a discrepancy in the prevalence of smoking in people with HIV. And so if you look at the estimates from different Western countries, depending on the data source, there's probably at least a twofold increased prevalence of smoking in people with HIV and people without HIV. And so some good data around that from the US comes from the NHANES survey. So a survey that's meant to be, and their sampling strategy employs a system where it's representative of the whole US population. So in 2016, at that time, an estimated 47% of people with HIV were currently smoking. If you look at any smoking behavior, that's closer to kind of 2/3 people have had some smoking in their past, and that's compared to 25% of those without HIV. Now, some good news out of that is that there's comparable quit rates, right? We're seeing globally smoking decline across the US population. And at this time in 2016, when these 25% of estimated people without HIV smoke, now that number is in the high teens in terms of people in the US who smoke. That's great. And we're seeing a similar decline in people with HIV. I think what's important is that as smoking goes down across the US, it's actually become more concentrated in groups that face other disparities and is very related to social determinants of health. And I think if you think about people who smoke in your clinical practice, you probably realize that that's intuitively true, that people in the 1950s who smoked are very different than people in 2023 who smoke. And so smoking is increasingly related to things like race, mental health, and other substance use and abuse. So I like this because it's not epidemiology data adjustments or like hidden, we adjusted for age and other comorbidities. This is just raw data, right? So it actually understands that all of this difference isn't related to smoking, but it's just rawly what happens to people who smoke versus people who don't smoke in a Western country. So this is from a national cohort of pretty much all people in Denmark over the kind of decade of the 2000s, looking at the life expectancy of people who smoke with HIV, people who never smoked. And you can see that there's a huge discrepancy, what ended up being about 17-year discrepancy in the life expectancy if you look at a 35-year-old current smoker versus a 35-year-old never smoker. And then that 35-year-old never smoker is really, nearing or at parallel, which we see in other studies, of people who don't have HIV. And there's other data streams that actually suggest a similar finding that smoking has more of an impact on life expectancy in people with HIV than people without HIV. So then the question is, do the strategies need to change? Do we need to think about smoking cessation differently in people with HIV. And I would say that the data is a little bit mixed and limited, but would generally argue that cessation strategies that have been developed and tested in clinical trials in large cohorts in people without HIV can largely be applied to people with HIV. So when we look at observational studies that basically look at a broad range of strategies that clinical programs provide, which includes some combination of counseling, medication, nicotine replacement, that if you look at settings where access is equal, which has largely come from health maintenance organization settings like Kaiser, that actually these strategies are as effective when employed in these clinical settings for people with HIV as without HIV. In other settings, the concern is that most of us practice, and I would say even the University of Washington and other private insurers are somewhat under this model where access is not controlled for, right? Access is a piece of the puzzle. In these settings, people with HIV may be less likely to be offered cessation therapy. And that is probably multifactorial and not directly related to HIV, but more related to other social determinants and insurance status. In terms of some of the things that hopefully can reassure us in providing this therapy for people with HIV, I think the safety data always comes up, right? So just know that there is broad safety data, including phase 3 trials for pharmacologic therapy in people with HIV. And for two big reasons, I would strongly consider varenicline, which comes in the brand name Chantix, over bupropion for two big reasons. One, Brandon's going to show you that the effectiveness data is just better for varenicline. So it hasn't been around as long, right? I think it was FDA approved in the mid 2010s, but is more effective. And there are some safety interactions that haven't been shown to actually affect patient outcomes, but bupropion may be less effective and may be less bioavailable in people on certain combinations of HIV medications that I list there. In terms of studies on the effectiveness of particular strategies, they're really limited and really in much smaller cohorts, as you might imagine, in people with HIV versus when people, recruit a large cohort independent of HIV status. And so there have been some studies to suggest that high may be better than low intensity behavioral therapy, but there's some other studies that kind of show that might be a wash. In terms of technology assisted cessation, I think that's a topic of really broad interest right now to think about, can we use computer technology? Can we use apps? Can we use smartphones to help? And that really hasn't been trialed in people with HIV. And in terms of pharmacologic versus non-pharmacologic treatment and really thinking about those head-to-head, that hasn't been shown in large data sets. And then the thing that I am most interested in from my side, where I combine cancer screening with tobacco cessation, is tailored strategies. So intersectionally tailored strategies are important. I don't think people with HIV, and I'm preaching to the choir here, they're not a monolith of people, right? They have other identities that are very, very important to them. And so we think about that kind of a holistic tailoring that can also be personalized to the patient. And again, these, maybe there's some preliminary data that they work, but they haven't been really rigorously developed or evaluated. So I use this slide to say, I think our treatments and our methods that we glean from general populations are safe, and they should be employed in people with HIV, and maybe we're not employing them as universally. So I think at a minimum on the clinical side, focusing on really deploying these strategies we know that work, and then maybe looking ahead to saying, how can we tailor these strategies for the population? So with that, I'm going to turn it over to Brandon.
So thanks, Maddie. So as introduced before, my name is Brandon Omernik. I use he, him, or his pronouns, and I like to begin any topic of conversation about tobacco cessation, acknowledging commercial tobacco use. In our program, we like to make the distinction between sacred or ritual use of tobacco, and we are referring solely to commercial tobacco products. So beginning with sort of an overview or rationale behind tobacco cessation programming. Ever since the 1964 Surgeon General's report, we've continued to see evidence and investment in research about the detrimental effects of tobacco use. And building upon that, in the most recent 2020 Surgeon General's report, indicating some of the troubling findings associated with e-cigarettes or vaping use, but noting that tobacco use is a modifiable risk factor. We know now that through evidence-based treatment practices, combination pharmacotherapy, and counseling, that tobacco use or cessation can be sustained over the long term. there's a variety of different clinical practice guidelines presented by the National Comprehensive Cancer Network, American Association for Cancer Research, or the American Society of Clinical Oncology, pointing to clinical methods for treating tobacco use. And that's what we use to integrate within our care at Fred Hutchinson Cancer Center, pointing to some of the persistent tobacco use and its associations with increased risk of recurrence for cancers, second primary cancers, and I would be happy to go into even some of the other factors associated with that. And then, as Maddie mentioned too, the availability of resources. So highlighting like patients' use of evidence-based cessation treatment is low, and we're missing a lot of opportunities to advise cessation and treatment. I always point to one statistic looking at general population data indicates that 70% of current tobacco users have a desire to quit, and that 65% of those individuals will attempt to quit within the past year. However, less than 1/3 of US adults who desire to quit or use cessation medications or counseling are advised to by medical providers. So I really appreciate the opportunity to be here to really advocate for a comprehensive approach. At Fred Hutchinson Cancer Center, we use what I had outlined as the stepped care model approach. We're modeled and based off the Memorial Sloan Kettering program. We begin with step one. Our goal is to identify all current tobacco users within our program, whether that's through rooming processes, universal screening questionnaires, or patient-reported use. And when we do identify a current tobacco user, because of the high motivation to quit, we like to offer our self-help materials. So we use a partnership with Dr. Jonathan Bricker, who is with Fred Hutch Research, who developed Quit to Heal. It's a smartphone app, and there is a publicly available app that I'll go into. And we offer a resource letter connecting patients to our program, inviting them to join our program in essentially an opt-out method. So we're going to contact them and address if they would like to schedule an initial visit with us and be enrolled in our program. And at that point in time, we step into the moderate intensity, which is utilizing we offer no cost combination nicotine replacement therapy through our program. That's sustained through a gift through the Snoqualmie tribe. But it's really what I think is the gold standard approach to our program, is being able to offer that access to medications without barriers for payments, insurance, and same with our counseling. I can meet patients as needed and moving into the maximum intensity. So we have patients such as our bone marrow transplant who have a hard deadline to quit, but we want to sustain that quit even through their treatment and afterwards. So we continue to work with patients long-term and work with providers to discuss using prescription medications. The next part is mostly a provider focused in assessing and addressing tobacco use. I like to refer to the 5 A's. It's a clinical referral model. It's built upon what used to be an ask, advise, refer, and adds in a little bit more detail about asking and then advising and assessing. So thinking about creating a routine habit of asking every patient about their current tobacco use and doing so in a motivational manner and really trying to build an open and collaborative approach to explore patients' ambivalence for their desire to quit or not to, and being supportive and knowing that there's an open door for them to access the resources that they need. So when advising a patient to stop tobacco use, I like to use an elicit, provide, elicit model. So eliciting desires and then asking a patient, what types of questions or concerns they have about this process, provide the information, and then check for understanding afterwards. And then when assisting the patients, going the extra step to say, great, I'm going to create a referral for you, but I'd like to be able to check in and see how things are going. So arranging for follow-up and adherence to a tobacco cessation programming tends to lead to increased use as well as patients' enrollment past the initial visit. So at Fred Hutch, we have a standard screener questionnaire that all of our MAs use within our rooming process. We go beyond the normal recommendation of If tobacco has been used in the past 30 days, we ask if any tobacco use in the past 6 months, including smokeless tobacco, e-cigarettes, cigars, and normal combustible cigarette products. When the patient provides a positive answer to that, we advise any of our providers to place a referral to our program, but we have the systems in place to be able to track that. And we utilize the EMR. In Epic, we use our smoking status to build a tobacco registry, and that's how we identify patients who maybe didn't get a referral to our program, but we still reach out to them for assistance. This is just a quick overview of some of the physical benefits of quitting tobacco use. I like to have these as sort of a back pocket way to overcome ambivalence or feelings that the damage that has been done from tobacco use. There's a lot of shame involved, and being able to point to that, even within a short amount of time, there's really some tangible physical health benefits to stopping tobacco use. So at Fred Hutch, our main approach to behavioral counseling, we currently operate with a program designed to offer counseling on an as-needed basis. Our standard is at least 6 weekly intervals of check-ins with patients, and then determining if a patient has stopped tobacco use during that time, or offering extended treatment and counseling beyond that term, and using a chronic relapse approach. We typically use motivational interviewing as our behavioral counseling modality. It's a person-centered approach using guiding to elicit an individual's motivation to change and identify ways in which the desired behavior does not align with their values and beliefs. So using open-ended questions, affirmations to explore the first part, the acronym DARN, is the person's desires, abilities, reasons, and needs. And as a person that expresses those change talk, we're able to then measure their commitment towards taking steps, whether that's medication adherence, setting a quit date, or even just tapering or beginning that process of moving beyond pre-contemplation on the stage of change. As providers, I like to offer the tool of using a 1 through 10 scale or ruler for assessing importance and confidence. A 1 through 10 ruler can be a simple question, such as a patient expresses an intent to quit, and asking them on a scale of 1 to 10, with 1 being not confident at all, 10 being highly confident, where would you fall on that scale about your confidence to quit? And exploring a patient's confidence in using motivational interviewing tactics to be able to move them beyond the scale if they're feeling not as confident, or if they're really confident, being able to ask, well, what are the next steps? If you're at a 10, you're highly confident, what are the actions that you will take to move into tobacco cessation? As Maddie mentioned before, there's some other behavioral intervention approaches. The most commonly used and most researched for tobacco cessation counseling is cognitive behavioral therapy, using the ABC model, and then mindfulness and acceptance and commitment therapy. Acceptance and commitment therapy is what we use through the Quit to Heal program or the Tomorrow Health app. Dr. Bricker is one who has researched a lot of that in terms of tobacco use counseling. So, but rather than explaining the ways that these work, I'd like to highlight that the modality of behavioral treatment itself can be flexible to meet a patient's needs. For example, we most commonly use telehealth or telephone visits, so we remove the physical barriers to patients having to attend appointments to be in person at Fred Hutch and South Lake Union. They don't have to deal with parking. We're able to meet them as needed, where needed. And I find that being able to do that for the patient shows our commitment to assisting them sort of while they're dealing with all their ongoing treatments or just the stresses of daily life. So, and there's also interesting research pointing to that telehealth or telephone visits and tobacco counseling, especially when looking at like state quit lines versus intensive programs, are pretty evenly matched in terms of treatment outcomes. It's being able to offer a more frequent check in with patients is where the data indicates that having counseling beyond the normal scope of what a state quit line offers the benefits. As for pharmacotherapy options for tobacco cessation, there's 7 FDA approved medications, and those are divided by sustained release medications, including the nicotine patches, bupropion, or varenicline. Nicotine patches provide a steady low dose of nicotine that reduces withdrawal symptoms. With the nicotine patches, what I like to highlight is matching a dose strength to somebody's current tobacco use. So if a patient or person that you're working with typically smokes anywhere from 10 to 20 cigarettes or more per day, beginning with a 21 milligram patch, and then scaling down, often there's a step 1, 2, 3 component to these, but identifying if somebody is at a lower use of tobacco throughout the day, that their adherence to using the patch might actually be better by matching something like a 14 milligram patch from the start, so that they're not experiencing any of the side effects from increased nicotine use throughout the day. And by matching with a 14 milligram patch for somebody who may be using 5 to 10 cigarettes per day, you're able to introduce a combination nicotine replacement therapy approach. So using gum or lozenges, we most often use lozenges with our patients because the education and ability to use lozenges is actually a lot easier, is what I have found, compared to gum, which requires a little bit of teaching somebody that compared to normal gum, it's not a constant chewing action. It's more of a chew to activate and then parking the gum to allow that nicotine to be absorbed within 30 minutes and then spitting the piece of gum out. A lot of people complain about how often they have to use it, and after a while it goes dry or tastes bad. So being able to work with patients to address those barriers. With bupropion, so it's using the generic name, or Zyban Wellbutrin. Bupropion increases dopamine and norepinephrine levels, but not serotonin. That medication's an especially good choice for people who are experiencing mild depression symptoms or they're very concerned about potential weight gain. And then varenicline, Chantix, it blocks a variety of nicotinic receptors in the brain, and it's most commonly cited to remove the pleasurable or rewarding aspects of tobacco use. Most often patients who are using varenicline will describe sort of a disgust with the flavor or the sensation of smoking, and that's where using in combination with behavioral approaches, teaching a mindfulness method for tobacco use, patients, instead of reverting to sort of the habitual thoughtless use of tobacco, tend to notice the physical side effects of the cigarette itself, whether it's inhaling and sort of that harsh feeling, or the flavor, or the smell. And those we can then explore as motivations for tobacco cessation. For a lot of patients who are concerned about prescription medication side effects, there's also a potential that they may benefit from reduced dose approach. So using lower dose varenicline or bupropion, if a person is expressing concern about the vivid dreams that they may experience or some of the jitteriness of the medications, and advising them that there is a titration period, typically over what's recommended, especially with varenicline, is that to get the full benefit of use, using that medication up to a daily use for 4 weeks is when it begins to have most benefit. So this is looking at sort of the effectiveness of monotherapies. And the one that I like to point out here, because everyone sort of has experience with it or somebody has expressed it, is the effectiveness of self-directed quit attempts, or cold turkey. And I'm pointing out that only 4.5% of unassisted quit attempts are successful beyond 30 days, whereas our estimated abstinence rates are looking at 6 months periods. And so by introducing any type of medication for the patient enhances their ability to remain quit over the long term. And even as a medical provider, directing a quit attempt and working with a patient to set a quit plan increases their estimated abstinence rate over 6 month period to 9%. So just having sort of that touch point to express that you're there for support and willing to work with a patient to establish a goal for tobacco cessation. So using a combination medication approach is that oftentimes patients are hesitant to use combination patches plus fast acting NRT like the lozenges or gum. I like to address that right away in asking patients if they have any concerns about combination approaches, because oftentimes there is a hesitance towards introducing even more nicotine. And one way I like to think about that is that there has been enough evidence in terms of patients who use a patch for an extended period of time, who continue to use combustible tobacco products or vaping. And so our bodies and brains have sort of a tolerance threshold for what is an acceptable amount of nicotine. And explained that way, a lot of people understand that, oh, if I'm using medical grade nicotine, I'm able to tolerate up to a certain amount, and I understand what my sort of threshold is. And when they do hit that point, you can oftentimes, say, great, it sounds like your tolerance for nicotine is sort of diminishing over time. We can talk about where can we reduce the amount that you're using, and also using the nicotine replacement medications in combination with prescription pharmacotherapy really has an added benefit as well. And the last part on combination therapy approaches is that there's evidence showing that using it for a longer period of time can lead to more success. A typical prescription amount might be 4-6 weeks. If a patient is finding success and that is helpful, I often encourage, sustained use through 6 months even for a patient, so that they're comfortable in knowing that, great, this is an option that helped me. I've gotten used to the use of these patches and lozenges, and I know what I can go back to if I ever have a relapse or slip. And this is for your reference if you have any questions about prescription information, sort of what guidelines are, and how to educate patients about use. And some public-facing patient resources. The Tomorrow Health app, as I mentioned before, is a resource that uses the acceptance and commitment therapy approach that's tailored towards different behavioral health interventions beyond just tobacco use. And then the Washington State Quit Lines, or tailored educational resources for different populations. So I'll hand it over to Maddie to sort of give a conclusion, and I'm happy to go back and review any of the slides or content that you may have questions on.
Thanks, Brandon. Yeah, that was super helpful. And I think I can only speak to myself and say how little education we get around tobacco cessation as part of our training as clinicians and care providers in various forms. So it's always a great refresher for me. And I will only say, I think that intimidation barrier is high around the prescription or advisement around these combination nicotine replacement strategies over varenicline. And so I think getting over that hump seems to be one of our biggest things with providers. And we've worked on pathways around that within the Fred Hutch program about how to encourage providers to provide that prescription for patients. So we can talk about that. But I want to definitely have time to open the floor. So just in conclusion, I think knowing that tobacco smoking is twice as common in people with HIV, and I know you all have a long list of preventive health things to work on, but I would encourage you to think about smoking really high on that list. That cessation treatments are safe and effective in people with HIV, but the data is just not really there yet on the most effective strategies or ways to tailor strategies optimally for the population. And then effective treatment often involves, as Brandon mentioned, the systematic identification of people currently smoking, however that works within your system, a really strategic approach. And there's many approaches, as Brandon presented, to longitudinal counseling, and then really having multiple methods in your back pocket that can be combined and then tailored to individual patient preferences and desires and ability to use. So that's all we have, and we'd love to answer some questions.
Thank you for watching this edition of the Mountain West AETC Project Echo Didactic Series. If you like this talk, please click the red subscribe button and please check out other talks in our series. Until next time, this is Brian Wood, Medical Director, signing off.